afternoon, Ian. Thank you so much for joining me for a conversation around COVID in the world of drugs. Could I ask you to start off by introducing yourself, telling us where you are in the world on May the 19th, 2020, and what you do for a job?
Well, I'm Ian Hamilton. I'm a researcher and lecturer at the University of York in the UK. Prior to that, I worked for about 15 years with people who had drug and alcohol problems, and I've carried on that research theme at the university. And I'm in God's own country. I'm in Yorkshire at the moment. So yeah, very lucky boy to be in Yorkshire. And I was saying to you earlier, you know, we've been really fortunate up here. We've been pretty immune from everything that's been happening, I think, in some of the bigger cities. But, you know, obviously very concerned about colleagues and people we know.
I was going to say, surely anyone who comes from Yorkshire will say it's always a good day to be in Yorkshire, and it's that Yorkshire genes that are clearly going to tell a virus and anything else just to sod off.
Yeah, that's it. That's been the response here, I think.
Constitutional resilience. So you have broad research interests, but one of the areas is the overlap between mental health and drugs and alcohol. Can you tell me a little bit about what COVID has taught us around the disparity between how we deliver mental health and how we deliver drug and alcohol treatment, and how we might actually learn to make things better moving forward?
Yeah, I mean, I think anyone who's involved in research, or even someone who knows somebody, a family member or friend, can't help but be struck by the overlap between mental health and drug and alcohol use. You know, for most people who experience a drug and alcohol problem, they will have at some point also something like depression and anxiety, or even a social phobia. And likewise, for people who have mental health problems, quite often the route in is through drugs and alcohol. You know, this can trigger a range of problems, and I guess one of the ones that probably sparks a lot of debate is around cannabis and psychosis, and we still haven't got that fully grounded yet. We know there's an association, but beyond that, that's about as good as the message gets. We can't say one causes the other. So there's all these kind of different relationships between particular drugs and particular mental health problems. But zooming out from that, yeah, I mean, COVID, I think, has seen really some really stark examples of how we've underinvested in both. And, you know, my reading of it, I don't know what yours is, Adam, but I think people have been pretty much left to their own devices, certainly in the UK and certainly in the US from what I'm seeing over there. You know, I think services, you know, obviously I've had to respond to things like social distancing, but of course what that's meant is, you know, in therapy and treatment, we rely on contact, we rely on face-to-face, we rely on humans being with humans, and it's stripped all that back. Even mental health services for people who are seriously mentally ill, you know, a lot of that has evolved to online contact or telephone contact, and the same for people who have drug and alcohol problems. So I think we've lost a bit of humanity and a bit of the person-centered, to be Rogerian for a moment, approach to treatment. And now that might actually... Sorry, go on.
I was saying, I'm just going to take a look back. Your camera's moving up a little bit. Are you touching?
Oh, is it? Sorry.
Screen, or yeah, it either looked like you had kind of resting Parkinson's tremor and you were on your laptop. So yeah,
let me try that. See if that's better.
That's just perfect.
Okay.
So lovely. So I'm pleased to see your Parkinson's has stopped, because we've got a still camera now. I mean, in the UK and elsewhere, mental health and drug and alcohol services were already critically underfunded and were already in crisis. So the chance of them being able to step up in a way and deliver even better treatment at a time where things have been under such pressure was always going to be limited.
Yeah.
But I want you to draw some parallels between the ways people working in mental health have gone out and engaged groups.
Yeah.
What is drug and alcohol?
Yeah, so briefly mentioned earlier, there was a lovely example in The Guardian yesterday of a reporter who'd gone to work with a couple of people in Change, Grow, Live, I think it was in Edinburgh. And Nothing very complicated, nothing very fancy, and yet it made the news that these two workers, drugs workers, had been delivering methadone to people who needed it on a daily basis to their homes. And of course, some of them would have homes, but others are in temporary accommodation. Now, that's fantastic news, but in 2020, it strikes me as a bit underwhelming. I'm really grateful they're doing it. I'm not trying to be critical, but I mean, you and I have been involved in mental health for a long time, and we've grown up with things like assertive outreach in mental health, where you literally run around the community chasing people with mental health problems until they submit to the fact that they've got an issue and they accept some kind of contact.
Well, you're proactively going out and trying to engage the most vulnerable people for whom a structured clinic appointment doesn't really work. So the service molds around the need of the client.
Yeah. And let's be clear about that. That wasn't driven by altruism. That was driven by politicians. Virginia Bottomley, who was the health secretary back in the early 90s, Jane Zito, whose husband was murdered on the London Underground by Christopher Clunas. There was a whole range of homicides that led up to that remolding, thankfully, and reshaping of mental health services that resulted in a much more assertive outreach type approach. But in mental health, we'll take the drivers wherever we can get them. I think it was a fantastic outcome in one way. But looking back over the time I've been involved, and I don't know about you, Adam, but looking at the last 20, 30 years in addiction, it's been a very passive treatment approach. It's been, I've sat in clinics waiting for people to come to me and then, moan to the rest of my team about DNA rates, about people not turning up and scratching our heads, and it just strikes me as odd that, okay, so we have distinct philosophies at play where in addiction, the prevailing philosophy is come and see me when you're ready to admit to something needs to be sorted. In mental health, it's the other way around. We treat you like a child and we, parent you. It's not an adult relationship. We try to assert really sometimes for some people that they must have treatment and they must have therapy. I'm being a little bit blunt and a little bit cliched, but you get the point. There's two very different philosophies at play. And yet we started this conversation by talking about overlap. Some people have both issues. Many people have both issues. So how they make sense of these very differing philosophies, I find it confusing. I'm not sure how they find it. And so if COVID and this last few weeks is going to kind of teach us anything, it's that we can actually do things without costing a lot of money. So for example, the workers in Edinburgh going around and seeing people on a daily basis who need that type of support, that doesn't cost a huge amount. I'm guessing they haven't got clinics that they're running, so they have the time and capacity to do that. But wouldn't that be great if we could evaluate that, see what difference it makes, and adopt that, and work with colleagues in mental health to look at some other tips of the trade, as it were, and some other lessons that can be learned about how to effectively engage people who are really, really difficult to engage. I'm not trying to do anyone down, but you and I know what some of these people are like. They're, rightly or wrongly, can be really difficult to have conversations with. And, it's maybe my failing sometimes, but, they be quite distrustful of people like you and I. They haven't had a good experience. So engaging them in any way, I think, is a fantastic achievement.
So what you're basically saying is, why has it taken COVID to even accept that we may have this thing called assertive outreach for vulnerable, marginalized people who use drugs, where you could link up with homelessness services, you could take treatment to where they are, accepting that for them prioritizing getting to a clinic appointment or the pharmacy, although we think that's the most important, they may have other reasonable priorities. They may not have bus fare, they may. And so, what you say is just, it's not
complicated.
No, it's nothing remotely complicated, but of course would have huge economic and social benefits. You'd be, developing a trusting relationship. You'd be hopefully improving those people's health. You'd be reducing their use of illicit drugs, maybe their criminality. You'd be freeing up clinic time for people who are more mobile.
Absolutely, and it's not lost on any worker in mental health. whether you're a psychiatrist, a psychiatric nurse, a drugs worker, counsellor, whatever, the one thing you learn after any training is that most of your training is redundant, because what people really need help with is social things. They need to know how to apply for benefits. They need to know, they need access to a roof over their heads, so none of this is complicated, but somehow we end up in these positions, don't we, where I think we're too immersed in it all, and some of that is, we can blame the system of, having to fill out forms and all the rest of it. But I think we also get maybe too immersed in what we consider to be important when the client is saying something else is important, and quite rightly. Eating, sleeping, breathing, all these kind of things are really basic. And yeah, you can go around and see people and give them the methadone daily, but you're doing a whole load of other things by doing that. You're checking that they're alive, you're making sure they've got enough to eat and drink, what's on their mind, what's causing them angst, etc., etc.
It's almost something I have to forget at an existential level, how useless so much of the things I do clinically are in the absence of housing, shelter, food, security. Like, I know it's a Band-Aid. I know it's so limited, but I'm almost embarrassed talking to you now thinking, why haven't I spent more of the last 20 years focusing on addressing those social determinants of health? And of course, because it's a huge problem, it's governments, but not always waving the baton saying, methadone on its own, if you're homeless and on the street and you're not engaging people, you're maybe doing what the government wants. You may be reducing crime. You're probably reducing a bit of death.
Yeah.
In terms of offering civil society an opportunity and citizenship, I mean, God, we fail badly.
We do, but I mean, I wouldn't be, I'm painting a really stark picture, of course, because I think you can't be involved in the clinic that you're involved in the previous work that I've done without addressing those social issues. It just becomes apparent really quickly. But I think we are limited. If you have a 20, 30-minute session with someone, whether you're, excuse me, a drug and alcohol worker, a psychiatrist, or a mental health nurse, there are certain things you're expected to have done, whether that's an assessment, whether that's going through some appraisal of risk, whatever it is. But of course, at the same time, you are being human. You are looking out for the person in other ways. But it's just, I guess, we all need to be reminded what is actually important. And of course, one influences the other. You could say that without that daily methadone, the person can't get it together to go and book to see their family, whatever. So it's not, it's not one thing without the other. It's both. But it just, I suppose what I'm saying, Adam, is if I was in charge of training, and make sure everyone got a kind of dose of what benefits is like, as well as psychopharmacology, and how to navigate the system, which is what you spend the majority of your time doing, really, in practice.
Yeah. Look, I understand methadone is a lollipop that brings people into treatment, that hopefully you can do those other things. But we also know in the last 15 years, funding has been cut back so much for all those peripheral social supports that very often that methadone does become really important, but it doesn't lend itself to the real potential benefits it could offer if you offered things wrapped around.
No, and also I think the other aspect to this is confidence. What I found, including myself, I'm not trying to diss anyone else, is that when your experiences in drug and alcohol treatment, you can be quite wary and almost uncertain of how to deal with people who have, let's say, depression and anxiety, or a history of abuse. That's one that I hear quite a lot from workers. And they're coming at it from a good place. The reason they don't want to do anything with that is they don't want to make things worse. Flip that around, and a lot of mental health workers, whether you're on a ward or in the community, or in whatever setting, sure, some of them, like every member of society, or some members of society, can be quite bigoted about people who use drugs and alcohol, but the vast majority aren't. It's just they lack confidence around knowing what to do. So another unintended consequence of having these separate systems for in terms of commissioning and providing drug and alcohol treatment, mental health, is people become siloed in their knowledge, confidence, and experience. And of course, the client doesn't present that way. They don't, present the one half of themselves at a time to the worker they're seeing. Those problems are interlinked, and they need interlinked attention. We can't neatly separate them out. Now, I know let's think about some cliches that you and I will have heard, and people watching this, I suspect, will have heard. Unfortunately, they still go on. So you hear of reports of people saying either they're admitted to a psychiatric ward or they're being referred to a mental health team, and nothing can be done because they're using drugs and alcohol in a problematic way. And that's, I think it's becoming less of an issue, but I think it's still there. And it's an extreme example of what can happen. I think more generally, as I say, the problem is confidence. So in the mind of, if I can bury into the general mind of drug and alcohol workers, they imagine people's mental health problems to be really severe, like schizophrenia and bipolar. And while some people do have those problems, the vast majority of people they're going to see are going to have things like affective disorder, depression, and anxiety. And likewise, for mental health workers, they're not going to see people in the main who are running around injecting anything they can get hold of. They're going to see people using alcohol, tobacco, cannabis, the things that we have good evidence for, we know how to intervene, but those interventions don't require high order skills in the main, but they do require confidence and interest. So I think that's really critical.
No, I absolutely agree. And I would have thought in terms of the most significant benefit would be to get both people with mental health problems and who have got significant drug and alcohol problems to stop smoking. Like, that improves people's mental health and improves their chance of having a longer, happier life. I think one of the other issues is that most psychiatrists don't deal with relatively simple low-level anxiety and depression. So the drug and alcohol team refers someone with an affective disorder to a psychiatrist, and they go, yeah, sorry, we deal with bipolar, schizophrenia, GP. And then someone in a mental health unit says, look, I've got someone smoking lots of weed, would you see them? And the drug and alcohol service go, well, we're not terribly skilled in cannabis use. So the respective areas we each spend our time in don't really match the requirements. And I think dual diagnosis has ended up being a useful waste bin diagnosis for both parties to go, no, I'll treat their depression when they stop drinking. No, I'll treat their drinking when they stop depression. And it doesn't work for anyone, most of all the client group. Moving forward, from the lessons we may learn, what changes would you like to see to drug treatment in the future in the UK?
Well, I think they've already started happening. Again, to try and draw a positive out of what's happened over the last few months across the world with COVID, is that services have had to default to, if you like, a hands or an arm's length approach to intervention. So they've had to do that over the telephone. They've had to do that online. So it's really accelerated that process. Everything from having systems in place, if you're a treatment body, to the IT ability of your staff, literacy of the clients and the staff involved in those conversations, but also, I guess, adopting, as we would face-to-face, an evidence-based approach to that. It's a bit like, what makes me laugh, it reminds me a bit of one of the really odd things about mental health is the greatest evidence we have is for family work, and yet it's the least practiced.
For people with schizophrenia.
Sorry, for people with schizophrenia, yeah. So you have this weird dichotomy of having super evidence, but virtually no practice. And I think the same is true of, kind of thinking about online treatment as well. Is online treatment isn't just about, someone logging onto a website or phoning them up at 3 in the afternoon and having a chat. That needs to be informed by what actually works for them. How intense does that need to be? What should be the focus of the conversation? How much of this is down to what we expect the client to do? How do we match up as we do face-to-face, the therapist and the client? Who's best to deal with who? So there's a whole range of things I think will follow on from this, but at least we've started. And I think, in fairness, some treatments, certainly in the third sector, Change, Grow, Live, other big organisations were doing some of this, but they've had to really accelerate that process. I've not seen evidence of it yet, but I am hoping, irrespective of the fiercely competitive tendering process that those different organisations are involved in, which don't actually aid collaboration, I'm hoping what COVID might do is actually get people to work together on this, because we need to learn the lessons from each other, and that's something that could really help accelerate the process again.
I love the fact that you've raised the whole idea of IT health literacy among our client group as well. I mean, I'm worried enough by the fact that most of the printed documents that we give to our patients require a reading age of about 15, where the average reading age is 11. The idea that there is another level of literacy that we may need to educate people in order that they can better utilize services is a challenge I hadn't thought about. I think online just gives people another choice of treatment modality, you know, to supplement face-to-face, maybe replace. It's about choices for people. But the one thing you've met that I haven't given any thought about is clients being able to choose their key worker on a bunch of ratings from other workers. Like there's, we should have drugworkertripadvisor.com where, you know, female patients who used heroin rated these kind of, you know, workers most highly. I mean, it might be that some people don't get rated highly at all. Well, that's part of professional development. But I also think that would, I mean, there's nothing more educative. Educative?
I know what you mean.
Word. Exactly. And then occasionally clients turn around and just give you, you know, I'll say to them, is there anything else you'd like to discuss? And the patient might turn around and say, I wish you would talk more slowly. Like, oh, yeah, right. Or, you know, you mentioned something really important, but I didn't understand it. And being able to get that really honest feedback from clients about things that are positive and things that are not. And, you know, I just think you're a patronizing twat. It's like, okay, can we think about that? I don't want to be a patronizing twat, but, you know, that's part of medical school. So I love the idea of client feedback helping us become better at what we do and learning who we work best with. You know,
I think as long as we don't overthink it, Adam, you know, the beauty of, there's a lovely little paper by Bill Miller, you know, motivational interviewing guy. But look, it's called The Forest and the Trees. I can't remember where it's published, but that's a lovely paper looking at what do we actually know about the evidence for treatment in addiction. And maybe not everyone will agree with this, but I sign up to his train of thought on this, is that actually the core tenets of empathy, hope, honesty, etc., trust, all these kind of very sometimes basic communication skills, although they're not basics, you know, the ability to reflect, summarize, clarify, ask open questions, etc., and listen, are really what makes the difference. And of course, that's the therapist effect. It doesn't. You can call it DAS therapy, you can call it GDS therapy, you can call it what you like. It's the person delivering it that matters. And of course, we'll all take a lifetime to hone those skills. No one can say, I'm the best reflector you've ever met. I'm the best empathizer. You know, so it's something we all have as an ambition. We all try and hone. And we use that feedback that you mentioned from clients, from peers, or even, you know, some insights that we gain in moments of reflection or epiphanies even, to kind of take that on board. It's just how well that translates online. You know, how can you be empathic online when you can't touch, you can't see the person's eyeballs as clear? You know, how well does that translate? So all those elements, I think, are really critical. It would be interesting to see over the next few months how much they translate into an online or remote world as well.
Yeah, I don't think it can ever replace that physical shared presence, but I think can augment and facilitate ongoing communication. Once you've met someone, it's like, I don't ever want to see you again, whether it's face-to-face or online. You know, that's simple. But if you've met someone face-to-face, it's like, I think I can trust you, work with you. hey, you don't have to travel 15 miles to come and see me. We can do this online. Would you like to do that? Yes, no. In that case, carry on coming to my office.
And I think the other aspect, Adam, to this is that although some mental health services operate 7 days a week, most don't. And certainly, to the best of my knowledge, most addiction services don't operate 7 days a week. So we lose a third of the week, particularly for those people who are new into treatment. We leave them for 1/3 of the week to do their own thing. So I'm not, trying to suggest that everyone start working weekends, but I think we have to look at that spot in the week, certainly for the first month or two when we're engaging these people and they're trying to re-establish or even just establish their new life or get to grips with that. To have, such a big hole in the week where they're left on their own, I think must be really tough. So I think, sorry, go on.
Well, no, I was going to say in hospitals operate 7 days a week. After hours, there'll be an on-call, medical registrar or an on-call psychiatrist. It's not beyond the realm of the possibility that after 5 o'clock in the afternoon, there is someone online who you can contact and see face to face, and there's an on-call rota. That's part of your working week. And you just make yourself available. I remember once hearing David Moore, who's an ethnographer from Australia, talk about how people who work in treatment services talk about their chaotic client group and they can't turn up to appointments. And he turned around and went, you've got it wrong. You have a structure of service delivery that doesn't suit the needs of your clients. Stop blaming your clients and change the way you deliver service. And in a way, that's what I think we've been talking about for 20 minutes. It's being passive is easy, but it doesn't get the job done. It doesn't help those people. And it's not difficult. It'll be interesting to see if the funding follows these conversations, Ian.
Well, I think that's going to be the challenge. But as I say, I don't think some of this is resource heavy. And I think we're, credit to third sector providers who, in the main are providing treatment in the UK now rather than the statutory services. They've had to be nimble. They've had to be flexible. My God, like you're intimating, they're going to have to be a lot more flexible and a lot more nimble going forward because, the screw's just going to turn on the resource tap, really. I think we're going to see, it's this really odd thing, Adam, isn't it, where we're going to look back on the last 10 years and think, my God, funding was great.
Bloody luxury.
Yeah, exactly. There's a depressing thought to finish on.
I was going to say, what's otherwise been a really uplifting conversation. So look, Ian, thank you so much for taking the time to give us a really interesting overview of how services have adapted and how we now need to learn from those and evaluate them. But what I'll take away from this is we take treatment to clients in a way that suits them, and we need to move away from a service structure that suits us to turn up at work at a fixed time and go home to our houses at the end of the day.
Good point. Nice
Ian,
one.
thank you so much. Stay safe.
Cheers, Adam.
All right.
Bye.
Right, and then I see the disinfectant where it knocks it out in 1 minute. And is there a way we can do something like that by injection inside or?
Just taking it one day at a time. Still don't know what I'm trying to find. Really,